is Dr. Timothy Quill, who is a professor of medicine, psychiatry, and medical humanities at the University of Rochester School of Medicine and Dentistry. And Dr. Quill has published widely, and I've been following his writings and enjoying them over the years. He has thoughtful, forward-thinking, and at times provocative views on palliative and end-of-life care, and I look forward to hearing what he has to say about palliative options of last resort.
Thank you. It's a pleasure to be here with you today. It's also been really fun to hear such unique perspectives on these topics. It's rare. You know, I go to a lot of conferences. It's rare you hear new things, and I heard some new things today. So that's good. That's a very good thing. I don't know how new my things will be for you, but I certainly hope that I challenge you a little bit in your thinking about this, try to have you think through some of these issues a little bit more thoroughly. Just in the interest of full disclosure, I have been an advocate for legal access to physician-assisted death in the United States. I've written a lot about this. I'm known for this topic, so you're just going to have to hear what I say with with knowledge of that perspective. So anybody recognize this lady? So Kubler-Ross, you know, who first started writing about death and dying in the United States and England back in the 1970s. And she did this radical thing. She actually listened to people who were dying, and she learned that they had a lot to say. They had feelings about what they were going through, and she divided these up into stages. Maybe her stages were a little too neat, but she really articulated that there was an inner life that people had who were dying, and that if we would be willing to listen, we could learn a lot from them. So I take care of a lot of people who are really sick. I take care of them at home and in the hospital. Some people like to talk about end-of-life issues. I envision this guy as not being a big talker about end-of-life issues, right? But he would be a guy at home, perhaps on a hospice program, that would give away his tool collection to his grandchildren. Moments that you would never, ever forget and really cherish within a family. So again, some of the deep death talk happens, sometimes it doesn't happen, or sometimes it happens many layers differently. There's an expertise to this process of caring for people who are really sick and dying. If you're going to have to be dying, which we all are going to have to go there someday, you want somebody who knows what they're doing in terms of managing symptoms. And you want that whether you're going through aggressive treatment or whether you're going onto a hospice program, where the whole job is palliation. So when we help people die peacefully, we are doing a really good thing. And again, do we help people to die? If we're in hospice and palliative care, we better come to grips with the fact that we do that. And we have to do it because folks are dying anyway. And we've got to try to have that happen the best way possible for them. And when we can make it and help it happen very peacefully, that is a very good thing. And we sometimes have to think way out of the box to make that happen, but we should be willing to do that. Some of it is really hard work, and not everybody dies peacefully, right? And we have to have a certain amount of courage to both listen to and care for people who are this sick, to be with them, if you will. It's not all, even with the best possible hospice care, it's not always all kumbaya all the way through. It can be very tough, and there's a lot of data about this. Also, if we're going to care for people with all kinds of illness, perhaps this guy might have bad COPD or lung cancer, we're going to have to learn how to care for people who fall off cliffs at the end of their lives, like very bad shortness of breath. When you have shortness of breath, it's actually something really genuinely to be afraid of, because you're okay up until about maybe a day before you're going to die, and then you fall off a cliff. And you have to have a bold way of dealing with shortness of breath. So if you're not bold enough about it, this person is going to get intubated every time, because being intubated is better than undertreated severe shortness of breath. So you're going to have to learn how to do that if you're going to care for these folks, and it takes a certain amount of boldness. Now, if you happen to be poor, or in the United States, black or Hispanic, you don't really give a hoot about physician-assisted dying. You're looking to get into care. You want to make sure you get enough care. So this is not an issue for everybody. It's really an issue for the haves, by and large. because the have-nots want to make sure they get the best of care, and they may not trust the system enough once they get in to think about what kind of options they might have at the end of their lives. Now, again, this is one of the recent well-known cases in the U.S. Brittany Maynard had an advanced brain cancer and became an advocate for wanting a choice at the end of her life. And again, this really raised the profile in the U.S. of the discussion. So again, this was a case that was hard to escape from and hard to really not at least be able to imagine a little bit what she was telling people very clearly, that I want to live as long as I can, as well as I can, but I want to skip the last part if it's really hard. And just in case you think she didn't have a big brain tumor, she had a big brain tumor that had been heavily treated and was now about to do the bad things that brain tumors do at the very end. So she, again, wanted to skip that last part, and she became a very compelling case in this discussion in the United States, which, again, has gotten, like in Canada, gotten a higher profile in recent months. So why are palliative options of last resort really important? Many people have seen bad death in their lives, in their personal lives. And some of them, those of you who work in hospice and palliative care, I will venture to say that if you have a bigger program, all the time there's one or two patients who are really having a tough time, having really tough to treat symptoms. And you're trying to grapple to come to grips with those. So we've all witnessed bad deaths, even with good palliative care. It's not like it's unheard of. So if you have witnessed that, you might wonder, gee, what kind of options would I have if I went through that kind of a circumstance? So I want to know, is there some possibility that I could skip that last part that's really hard? You might wonder about that. And awareness of what those options are can be very reassuring to some people, particularly those who've witnessed bad death. So again, when you look at what drives this conversation, it's because people have seen a little bit too much sometimes. And sometimes it's been from inadequate palliative care. Clearly, then the answer is better palliative care. But sometimes that has not been the reason. Sometimes the reason is that disease can be pretty tough sometimes. So again, if people are having bad symptoms, the first place to go is to make sure they're getting the best possible palliative care. So if they're not getting if they don't have the palliative care team involved, you get the palliative care team involved. If their clinicians caring for them haven't been adequately trained, you find folks who've been adequately trained. You make sure they have access to the best possible pain management. You want to make sure the palliative care team is engaged and involved because, again, the first place, that's sort of the floor. And you want to make sure the floor has been achieved before you start thinking about any last resort options. But there are some limitations to palliative care that I consider to be uncorrectable. When we tell people that we can relieve 100% of suffering, and I've heard many hospice and palliative care clinicians say this, I frankly think it scares people. Because I think they think, boy, if I'm going to get into a bad situation, they're going to pretend like everything's okay, and I'm going to be out there on my own, and that scares people. So we need to learn how to acknowledge the exceptions. We can talk about how we approach the exceptions. And some of those exceptions are uncontrolled physical symptoms. Again, uncontrolled pain, I think I have pretty good answers for that. Uncontrolled shortness of breath, less good answers. Severe delirium at the end of life, less good answers. Fear and all kinds of spiritual, psychosocial, and existential issues at the end of life, less good, simple answers. Dependency and side effects of some of the treatments, particularly for fiercely independent people, tougher answers. And again, so again, we talk about, we see people all the time in palliative care who might be on life supports who say, I've had it. And what is our answer when we're seeing somebody in the hospital, they're on a life support? The answer is listen to the patient. Right? The patient knows what he or she needs. People have the right to refuse treatment, but take that same patient or patient suffering 25 or 50 times as much without a life support to stop. And we say, there must be something wrong with that patient. They have an exaggerated need to control their future. They must have a pathological need for control. So again, some of these places we put people seem to be unfair in some circumstances. So again, the prevalence of symptoms in dying patients, it ain't just pain, it ain't just shortness of breath, this is just data about symptoms in dying patients. So there are lots of symptoms at a lot of levels. Unrelieved pain in the terminally ill with ordinary pain. Again, it's quite prevalent in ordinary pain, but even on hospice programs, there's moderate to severe pain in a fair number of cases. Now, some of these cases are because people don't want to take strong pain medicine, and that if they were willing to take strong pain medicine, we could probably relieve the pain. And in particular, if they were willing to accept the sedation that comes with very high doses, I think we could say we can relieve almost every kind of pain. But again, for those who want to be alert and awake for their final time, that's a tougher trade-off. So again, unrelieved pain at death on hospice programs. These are some of the luminaries of hospice and palliative care in the United States. And again, it just shows that, again, bad pain or poor pain control at the very end of life on hospice does exist. And similarly with shortness of breath. Shortness of breath is quite common in the very end of life and sometimes getting very severe toward the end of life. So these are just symptoms that do occur that we are sometimes struggling to relieve at the very end. In Oregon, about 85% of those who seek assisted dying, Oregon where it's legal in the United States and has been so for about 16 years or maybe a little bit more than that, are receiving hospice care. So it's not that they see this as an alternative to hospice. The 15% who are not on hospice have access to hospice. They just don't want hospice. They're more interested in other issues. Unrelieved pain is rarely the major reason. It's more often in Oregon loss of control, tiredness of dying, general debility. It's often a large combination of things that people find unacceptable. So there are some interlocking public policy questions. How do we improve access to and delivery of palliative care services, including hospice, to all dying patients? Because that's the floor. You want to make sure people have the floor before we start providing any kind of last resort options. And then how do we respond to those infrequent but troubling patients who are dying badly despite excellent care? So that's the tougher question. How do we respond to those? And then do we respond to individual cases sort of underneath the cover of darkness, or do we create public policy so it's out in the open how we respond? That's sort of a big question. And I think that's a question worthy of struggle with a little bit. So there are two circumstances that are common when people might be faced with this issue. One is if you have a very bad terminal illness or a bad illness that's going to become terminal. My sense is that some of you would, when the TV goes off and the books are put down and you're trying to sleep and you can't sleep, your imagination is going to wander a little bit. And again, if you've worked in palliative care, I guarantee you your imagination is going to wander a little bit. And what's it going to wander to? It's going to wander to some of the tough cases that you've seen, some of the bad deaths you've seen. So you sort of wonder, what would I do? And what if I have to face that kind of thing? And it turns out that people will talk about this. It's not rocket science. It's a matter of having a will to ask people to do that. So what kind of deaths have you seen in your family? How have people died in your family? Have you witnessed other kinds of deaths that worry you at all? What does a good death look like for you? These are questions that many people are willing to engage in. And again, when people say, well, my mom died and the doctors were afraid to give enough pain medicine, I must say I breathe a quick sigh of relief and say, well, you know, I'm very confident that I can relieve pain and I'll give you as much pain medicine as you need, and that's something you don't have to worry about. But if they're worried about some of the other things that I mentioned, then I think it's tougher to be simply reassuring. If I can reassure them, though, saying, you know, I will be with you, I'll be with you in this process, I'll make sure I'll be responsive, I will tell you that most people are then free to worry about other things and to spend their time and good energy on things that are much more essential than worrying about the worst case scenario. So this is a huge gift you can give to people, is making that commitment to help address that. However, if you do make that commitment, you have to be ready to face the music if they end up in a bad situation. So again, making the commitment without following through on it is abandonment, and that's the worst, right? So if you're going to make that commitment, you have to follow through with it. So what do terminally ill patients say about considering versus pursuing physician-assisted death? About 1,000 terminally ill patients, not including AIDS patients, about 60%, this is in the US, support physician-assisted death, and 10% are seriously considering. So there's a lot of background thought about this stuff. 92 terminally ill patients at a Catholic hospice in the U.S., 17% had a high desire for physician-assisted death. So this is on people's minds. Whether we choose to find out if it's on their mind is up to us. Who asks about it? Most commonly, patients with cancer, neurological diseases, particularly ALS, and patients with AIDS, particularly in the 80s and 90s, but still today. Most of the patients are white. Most of them are from Western culture. Almost all have medical coverage, and most have access to hospice. So this is an option that the haves generally want. The have-nots are not that interested in this as an option, by and large. Motivations, again, illness-related experience. So this is what do people say, why they want it. Feeling tired, uncomfortable, loss of function, pain or unacceptable side effects. Again, illness-related experiences, maybe a little bit around a half, maybe a little bit over. Loss of sense of self, desire for control, very big issues. And fears about the future, fears about not wanting to die, or like someone in my family might have died, fear about being a burden, and so on. So it usually is not pain per se. And again, usually in the discussion about this, it's spoken as if it was pain. It's usually not physical pain. It's a much broader notion of suffering and fear about future suffering. So again, we've made this commitment, and now out of this larger group of patients, a small group will talk about, will you help me die now? I am ready to die now. How many of you have met a patient who is ready to die now? Okay. Looks like about a third, maybe a little bit more. So again, the first thing to do if somebody's ready to die now is find out why now. Tell me more about that. Tell me more. Tell me more. What makes it so unacceptable? What's the hardest part? What's the worst part? And again, people will talk to you about this, and you can try to understand it. Sometimes it's going to be uncontrolled symptoms, in which case the first answer is to intensify symptom management. Sometimes it's going to be a psychosocial problem, a family issue, in which case it might be a family meeting of some kind. Maybe a spiritual crisis. How could God allow this to happen to me? In which case you might have a clergy or a chaplain come and talk to the patient. They might have gotten depressed so that they're not seeing their situation clearly, in which case antidepressants and a psychiatric consult might be the proper way to go. But it also may be that they have uncontrolled, intolerable suffering, and they may be really ready to die. And I venture to say that all of you have met people who are ready to die. So again, we're going to ensure all palliative care alternatives have been exhausted, and then if they have been and they are still ready to die, we're going to search for what I call the least harmful or the least worst way to respond. So there's nothing about this that's particularly elegant or necessarily morally uplifting. It's just we have to find a way to respond, because this, in my mind, is a medical emergency. It's got to respect the values of the major participants. That includes me if I'm participating in it as a clinician. It includes primarily the patient. It includes their immediate family, and then the clinicians. It's got to have patient-informed consent and full participation of the immediate family. Now, again, what counts as immediate family? Again, families are going to really tell us what counts as immediate family. It doesn't necessarily have to be every long-lost relative who's going to have to approve. It's really the core group who've been part of the process, because they have to make sense out of this as well. So here are a list of the last resort options. I'm going to briefly go over these. This is truly the way I think about these things. Okay, so if and these are in order of preference. So again, if I can find answers in the top categories, I am the happiest, because that is really wide acceptance of these practices. Middle category, I think probably legal, but get more controversial. And then the bottom category, I would say legally questionable in many parts of the United States, about to be legal in your neck of the woods. So accelerating opioids for pain. Opioids are the mainstay of pain management. Dose needs to be proportionate to the level of pain. So again, if we're going to up the dose, if people have severe pain, we can keep upping the dose as long as the pain is in a moderate to severe zone. There's a small risk of sedation, respiratory depression, although in point of fact, the risk of death with opioids is way overstated. There probably is much data that opioids save life and prolong life than risk death. On the other hand, if we are talking about a crescendo of pain at the very end of life, we are going to have to give very large doses. There is genuine risk to that, and we just have to own up to that. Wide acceptance that this is permissible, by the way, across the political spectrum. Death, if it comes, is really unintended. Now, again, if a patient starts saying, well, I also am really ready to die and I want to die, you just say, don't tell me that, because then I won't be able to manage your pain aggressively. You know, just kidding about that. So what about stopping life-sustaining therapy? So also, as somebody's ready to die, we're going to look around to see, are they on a life support? So again, if they're on a ventilator, it's pretty obvious they can go off the ventilator. Stopping dialysis, about 10% of people on dialysis die because they choose to stop dialysis. They are in a circumstance that is radically different from when they first went on to dialysis. And again, we go through the same large evaluation, but they can stop. Feeding tubes, intravenous fluids, all can be stopped. Implantable defibrillators, in the United States we have an epidemic of defibrillators going in, those can be stopped. Steroids for brain cancer, okay, so some people are on steroids, keeps their brain from swelling, they can stop steroids, and again, if they are ready to die, that might allow that to happen. These decisions can be made by patients if they're capable of decision making, and also by families based on substituted judgment. And again, widespread agreement that this is permissible across political spectrums. Patients have the right to bodily integrity that we need. They have to give us permission to do these things to them, and they can take away that permission at any time. Now going into the gray zone, voluntarily stopping eating and drinking. This is the result of an active patient decision. So this is not, there is a natural part of not eating and drinking that happens as people get really sick, and that is not what this is. This is people who are capable of eating and drinking, who choose to stop eating and drinking because they're ready to die. And again, the hard part about this and the necessary part of it is stopping drinking. If you drink sips of water, sips of liquids, this goes on a very long period of time. So it requires considerable patient resolve. It usually takes 1 to 2 weeks to occur, depending on how sick and debilitated the patient is at the start of it. It theoretically does not require physician involvement, although it really should, because people get symptomatic as they go through this process, and they also get delirious toward the end of it. And again, so you need some help with symptom management as the process unfolds. Palliative sedation, again, another, I think, on the edge kind of option. By the way, when you look at the prevalence of palliative sedation within hospice units and hospice programs, it's gobsmacking the variation. Okay, so some palliative care hospice inpatient units, almost everybody gets sedated before they die. In some cases, it's very rare. And again, I think if we're talking about sedation to unconsciousness, this should be a very rare phenomenon. When you go from 0 to 10 on the sedation scale, it should be reserved for unusual cases, should have second opinions, should really make sure you're very thoughtful about this. So again, process, depending on how sick the patient is going into it, usually takes days to weeks. Patient usually dies of dehydration. There is some debate about whether you could sedate somebody to unconsciousness and continue them on IV fluids. To me, that's crazy. Unless you, now there is a sedation, there are sedation holidays for really sick people where we are going to give them IV fluids and potentially put them on a ventilator while we support them and give them a rescue from their pain. Burn patients would be an example. That's different than this. This is terminal sedation. It's dying patients. So giving IV fluids during this process will prolong it, and that to me personally makes no sense. Although it, again, it could be discussed. Justification, combination of the double effect and withholding of life-sustaining therapy. Physician-assisted death, also called physician-assisted suicide. This is where the physician provides the patient with the means to end their life, usually a prescription for barbiturates, but the patient must carry out the final act by his or her own hand. The possibility of an escape is very important to some people. They will sometimes never activate it if they know that it's there. I remember an AIDS patient that I had many years who had saved up his huge stash of barbiturates that he kept in a blue sock. He was adamant he needed to have choice, as many of my AIDS patients were, and he died on a hospice program, sedated on a morphine drip in our palliative care unit with his stash of barbiturates under his pillow. So the the barbiturates were a security blanket for him, that he could be in charge for the last of this, but he actually died using standard hospice and palliative medicine ways. Physicians are, even though the patient has to take this by his or her own hand, physicians clearly, the prescribing person is clearly morally responsible. So if they're going to take it, you are morally responsible as a co-conspirator and an accomplice in this process. And you have to make sure you can live with that personally. And then we have voluntary active euthanasia. In this case, the physician provides both the means and carries out the final act. So it requires a patient request and consent from a competent patient. Physicians are more reluctant about this than they are about a physician-assisted death or physician-assisted suicide. Requires physician presence at the time of death, which is probably a good thing in some ways, although it's got some issues with it. It allows response to a wider range of suffering than assisted suicide. It's illegal in the U.S. and much more likely to be prosecuted. So Dr. Kevorkian, who is our maniac in this zone for a long period of time, people tried to put him in jail for physician-assisted death. They really could not convict him. But one case of euthanasia in the United States, and he was put in jail for 5 or 7 years or something like that. So it's, in the U.S., this is viewed very differently than assisted suicide. So some data from Oregon where this has been legal. Physician-assisted death has been legal now for about 16 years. It really accounts for 1 in 500 deaths, so it is not a common phenomenon. But 1 in 50 talk to their doctors about it, and 1 in 6 talk to their families about it. So it is part of the conversation in a lot of situations, but very few ultimately act. And I think this is true of euthanasia as well as assisted suicide. Almost all the patients are white, none lacked insurance, none were motivated by financial concerns, most had cancer, most had been through big battles against their disease, most are on hospice, and it's often a mix of psychosocial and physical factors. The silver lining in Oregon, there have been a lot of other improvements in end-of-life care, so there's more than, it's probably number 1 or number 2 in the United States of number of deaths at home, high rates of hospice referral, high rates of opioid prescribing in seriously ill patients. They have a statewide DNR-DNI program that's a model. And it's been a wake-up call for physicians. Almost everywhere else in the United States, if you give a palliative care conference, it's attended, about 95% are nurses and nurse practitioners attending. If you give it in Oregon, particularly right after the passage of the law, it would be 75–80% of physicians attending. So one of the silver linings is that people say, God, if we're going to give people these kinds of choices, we better get good at palliative care, because we don't want to be doing this if people are not going to have adequate palliative care. So how about where are things in the United States? Oregon, it's been legalized. Washington State by a referendum. Montana by a constitutional challenge. And Vermont by legislative action. Most of you may have heard that California, both sides of the legislature, have just passed a law that is now awaiting the California governor, who happens to be Jerry Brown, of all people. Those of you who are old-timers will know there's a certain irony to this. He's a good guy, but he is a very, very liberal guy and progressive. He's also a good Catholic, so it's not entirely set what he's going to do with this. New Mexico is also in flux, so there has been a lot of movement in the United States, particularly in the last year or so. What about Canada? And again, you guys know more about this than I do, presumably, but I put this slide in. The Canadian Supreme Court said that there's a fundamental right to choose physician-assisted death, either physician-assisted suicide or voluntary active euthanasia. Pretty remarkable. The criteria include, and again, this is right off of the law, grievous and irremediable medical condition. I don't see a lot of terminal illness in that definition. So again, it's a wide range of illnesses that could potentially qualify. That causes enduring suffering that is intolerable to the individual. So again, this is very progressive language. And you have 12 months to enact this regulatory framework before it's going to become law. This is going to come to a head in February, ostensibly. This just gives you a sense of other parts of the world. The Netherlands, Belgium, Luxembourg, Colombia, Germany, and Switzerland all have laws that allow assisted suicide and voluntary active euthanasia with some restrictions. Some of them have gone to include children in special circumstances, so there is a lot of flux in the Western world. So there are need for safeguards to protect vulnerable from error, abuse, and coercion, to ensure access and adequacy of palliative care. The risks cited for physician-assisted suicide are also present for other last resort options. So if we are going to do safeguards, we need to balance flexibility and accountability. So again, these people are very sick. Having them see 5 consultants before they're going to be allowed to make a decision is not fair. We have to think about what's the reasonable kind of consultant and what kind of consulting questions should be asked. So we have to balance privacy and oversight. The categories of safeguards, in my opinion: palliative care should be accessible and found to be ineffective. So again, it's not an alternative to palliative care. It's when palliative care doesn't work or is unacceptable to the patient. Rigorous informed consent, need to know what the diagnosis is and the prognosis, and independent second opinion, ideally by somebody with expertise in palliative care, and then documentation about what's really going on. What are the risks of a don't ask, don't tell? The don't ask, don't tell is what has been the policy in the United States and probably in Canada, although I don't know for sure in Canada, but I bet there is a secret practice just like there is in the United States. So don't ask, don't tell means that whether you get access or not depends a lot on the views and willingness to take risk of your doctor. I will tell you that's kind of a vulnerable spot to be if what kind of option you're going to have are dependent on that. It discourages explicit conversation, so you might be told, don't take too much of this or it might kill you. Well, what in the world is she saying to me about this? Is she suggesting that this is the time, or what does this mean? So there's a real risk of misunderstanding. No safeguards to ensure adequate palliative care and adequacy of evaluation, and potential bereavement problems. So again, if you do make a secret decision with a patient and family, that family is not going to be able to talk about that with friends, colleagues, and you're not really going to unless you have really trusted colleagues. So again, that makes bereavement much more complex than it would otherwise be. So the advantages of being explicit about last resort options: it acknowledges a problem, less patient and family fear, free energy for more important tasks. So again, most people want to talk about this. They want to be reassured they actually will never need it. It reinforces the clinician's imperative to be responsive, to not leave the patients and families hanging if things get rough, and to get help if they need it. And again, most people want to talk, very few actually act. Risks about being explicit about these options: some patients may be frightened by that, and I think that is a genuine risk. It might lead to pressure to prematurely choose death. There might be family pressure, it might be pressure to save the family fortune. I think these are potentially legitimate risks. It could undermine progress in hospice and palliative care, lessen our commitment to work with people who have difficult suffering, and provide an easy out when suffering increases. And it could undermine fundamental physician values. So the bottom line: only sensible in the context of excellent palliative care. Currently, options are unevenly and unpredictably available. In my view, all options should be subject to similar safeguards. And in my view, an open process is ultimately safer, more predictable, and more accountable than a secret process. Clarity about which options are available and under what circumstances would be beneficial. It would reassure those who fear a bad death. Are you giving me a single? No, okay. Increased responsiveness to extremes of suffering, more ability to address unique circumstances, and more accountability when suffering persists. So I'm going to close. How much longer do I have?
Technically, you're done here, but we started about 10 minutes late, so you technically have 10 more minutes. Keep going before question and answers.
All right, I'll do 10 minutes of a case. Do a case? Okay. So this is a case of a young man who was a resident in our internal medicine residency program. He was about to graduate. He was a third-year resident. He was going to go into primary care practice, and he was a really good resident in the sense that, you know, he took palliative care rotations. You know, he liked us in palliative care, and he thought that he understood that palliative care was an essential part of good doctoring. And so he developed a little bit of chest pain, and then he suddenly developed a lot of chest pain. And he did what all good doctors do. He went and ordered himself a chest x-ray. And so he ordered this chest x-ray. He started having a lot of pain, like serious pain. And so he ordered a chest x-ray, and it turned out that he had a big mass on the top of his lungs on the right side. So he then went to his primary care doctor, who was also his supervising doctor. And it turns out his primary care doctor didn't prescribe opioids, by the way. He didn't like them. He thought they were too dangerous. So he was now seeing his doctor having 8 out of 10 pain, facing some very tough decisions, and he couldn't think straight because he was in severe pain. So he realized at this point that he had to get a real doctor, who could address pain. This is when he became my patient. Now, again, having a resident in this circumstance as your patient is not a great thing, but you do it because he needed a doctor, and of course I was going to do it. So he looked like an adenocarcinoma. It turned out to be once he got his pain under control, we did a biopsy. It turned out to be a yolk sac tumor. And a yolk sac tumor is a rare tumor. It turns out that, again, I don't, as a primary care doctor, this is not something I carry a lot of knowledge about, so I had to go and do research. But it turns out it's got about a 30% cure rate. Now, again, the downside of a 30% cure rate, 70% no cure rate, right? So, and he was very aware of this. And so he started in on treatment. There's a set treatment for this, and of course he had every complication known to possibly occur. And I have just some video of him talking about this. Now, what made him even more challenging is he wanted the possibility of a physician-assisted death. He had thought about these issues a lot in his medical school. This was a guy who he liked to be in control, like many doctors do, and he was willing to talk about that. So he brought this up, and I have a little bit of video from him that I'll show you, hopefully.
And my wife and I immediately began to discuss end-of-life issues and what we were going to do if this turned out to be an adenocarcinoma. And we came to the excruciating decision that if that's what it was, we would not probably even pursue treatment and go through the hell of chemotherapy, given the fact that there's probably wouldn't be that much on the other side for us. And we talked about it, and we talked about it, and we pretty much decided that she would stop working, and I had stopped working at this point, and we would just try to spend some good days together and get me plugged in with some people who could help me through the end. And we made that decision when we were thinking that it was adenocarcinoma of the lung. Yeah.
Excruciating decision making. I mean, so fast. Right?
Yeah, this was 3 days after I was feeling I'm ready to move back and start my practice.
Right.
3 days later, I'm talking about dying.
Yeah. Had you ever talked about that or thought much about that yourself?
No, in my training as a physician, in my residency training with the University of Rochester, I think part of that training has been with end-of-life specialists in various forms or another. I think every year of my training I did interact with people either in hospice or in geriatric care, where some flavor of the month was end-of-life care. And I think during those times I had various people encourage me to think about what made life worth living, what my value systems were, and I had done that before, but this was totally different than sitting down and writing on a piece of paper what makes life worth living when you're healthy.
Right.
Yeah.
What will be the differences for you? What did you find when you're right up against it that you didn't know when it was an abstract thing?
I am. I think the list of what makes life worth living is what would be different, I guess, kind of. I think when I was healthy, I would write down things that to me would now seem inane, like, guitar playing. I like to play the guitar, and that would have been one of those things that makes life worth living.
Yeah.
But at this point, when I got into this mess, those things changed, and life worth living kind of means being able to interact with my wife, being able to speak with her and talk to her, and feel her presence. Just a lot more, in some ways, much more simpler things.
Yeah.
Much more simple things than, or much more basic things than I would have listed before as important things in quality of life. Yeah.
The opposite side of the coin is what things that would make life not worth living.
Right.
I'm interested in what those might be now and whether they're different from what you thought they might be.
Yeah. Yeah, I've thought about before what would make life not worth living back when I was healthy. And for me, it was such a nebulous kind of concept to come to, because not having to face that, it's just, you can list some things like, uncontrollable pain. Yeah, that's got to be on everybody's list of what would make life not worth living. But until I got into this point, I don't think I really was able to appreciate what life not worth living is like. Although now I think I've seen definite glimpses of that, glimpses of that. In fact, before in my whole life, I never could have uttered the words that life was not worth living. But I've been through that now, at least for a couple of days. Earlier, not early on in this, but after chemotherapy, which we haven't talked about, but going through the chemotherapy and having some subsequent problems that we haven't talked about, I've been there now.
And what was there? What
So in the interest of time, I'm going to stop, but he can go in and describe what that was like for him. And he clearly wanted to have reassurance that if he got there and stayed, that he could have an escape. And he needed to have that to keep going with his treatment. And I was able to verbally commit to that, although it wasn't completely clear what I was committing to. So again, which of the last resort options would he need in his circumstance? I'll give you the quick version of his story. He continued to have every conceivable complication, went through all of chemotherapy, and then when we re-imaged him, he still had a good-sized mass in his chest. Turns out that there's a world specialist in Indianapolis on yolk sac tumors, and we sent him to Indianapolis, and he said, there's a good chance that what's left is a teratoma, which is a benign tumor that's left that might be able to be removed. So he underwent major surgery for this teratoma, had every complication known to man coming out of the surgery, but ended up it was able to be fully removed, and he, over many, many months, recovered, and he's in practice now. So this is a good story. It is a story that says that people really need to talk about these things. It is on their minds, and we have to be bold enough to listen to them, hear what they're afraid of, try to reassure them as best we can. By the way, the reassurance doesn't necessarily require that you be willing to personally provide physician-assisted death. If you can't live with that, even if this becomes legalized in Canada, you should not provide it. But in my opinion, you then need to talk and think hard about what you can do. And you need to be able to talk with people about what you can. This is how I think about it. This is what I would do if you ended up in that circumstance. And I will tell you, for most people, if you'll commit to them, and short of that, that's sufficient. So let me stop on that note, and we'll have our panel. Thank you.